What if my father was the one waiting for that acute care bed that her husband sits in for a year? That's what's happening in our intensive care units. That's what's happening in the hallways of emergency care.
We know that there is really a lack of long-term care homes across the province. So again, it's an issue where I'm working with the Minister of Long-Term Care to develop those spaces in order for people to be able to move out of hospital.
How do you build a strong and robust home care system? You make PSW's job good job.
More emphasis on health promotion and prevention than what we do today. And it's not, our care system is not necessarily based on a medical model. We would be much better off.
From the Zoomerplex in historic Liberty Village, the Zoomer with Marissa Lennox.
Welcome to the Zoomer. I'm Marissa Lennox. Healthcare in Canada has reached a tipping point. Our health system was built over 50 years ago when the average age in Canada was 27 and life expectancy was much lower. Since then, it's remained essentially unchanged, with its focus on covering healthcare in hospitals and access to doctors, not to deal with the needs of a growing population living longer, many with chronic conditions. At the roundtable, we'll discuss the challenges Canada's health system faces, particularly by a changing landscape and an aging society. And we'll also compare Canada to other OECD countries on spending and performance. But before we dive in, let's tee up the topic.
Canada has some of the longest waits for medical care in the developed world. At the emergency department, a majority of Canadians wait more than 4 hours. And for an inpatient bed, the wait can take days. 1 in 5 Canadians wait 7 days or longer to see a family doctor, while over half skip the appointment altogether. The wait for home care services often stretches for months. And a patient needing a long-term care bed can wait years. But the real challenge is not just wait times, it's ensuring that Canadians get the right care at the right place at the right time. And this requires more than Band-Aid solutions.
David, I'll go with you first. Wait times has become a defining characteristic of our healthcare system. Waiting for ER, waiting for a specialist, waiting for treatment, sometimes even when the cure depends on timely access to treatment. When you compare Canada to other OECD countries on spending and performance, we pay top dollar and near the bottom of results. Do you think our politicians and our bureaucrats are prepared to accept that we are underperforming?
So far, no. I've been associated with this through CARP for over a dozen years. And the sort of three-penny trick that they do is they say, look at the United States, look at the United States, look at the United States. We don't want to be like them. They're bad. But they don't look at other countries that have single-payer health systems like we do, who are cleaning our clocks on this. So there's a lack of commitment to results. There's a reluctance to be measured by results. There's one white paper after another. There's one long-term strategy document after another. They rearrange the alphabet soup of what the different departments of the ministries are called. They just keep moving and looking busy. They never say no, but they never look you in the eye and say, other countries with similar systems are way outperforming us while spending less. This is the year, 2020 is going to be the year, I can tell you from, CARP's point of view, that we are saying enough.
Canada is often compared to Australia. And that's in part because Australia has a Medicare system, though they have a separate private component. But when you look at wait times to see a GP, wait times to access a specialist, they're much shorter in Australia.
That's because they generally have it is a co-payment system to a large degree. So it's whether you can afford or can't afford services and a co-payment system. But I can get in, when I was in Australia, and that was 17 years ago, I could get in to see my local GP the day I wanted to get in and see her. So I didn't have to wait for a week to make an appointment. I could actually get to see my GP on that day. And generally, most people can get to see their GPs. But the ratio of GPs to the population is not much different to what it is here in Canada. So my question is, why are we doing something differently What is different about Canada?
Well, what's interesting is that you mentioned a co-payment, and then you say easier access. Excuse me, but a co-payment is a barrier to access. So if I'm earning a minimum wage and living in Toronto, you know, a co-payment represents a barrier to my accessing, potentially. So that's the thing. Like, I don't understand how that kind of one translates into the next. Perhaps by reducing the stress on the doctor? I'm not sure.
No, in terms of accessing your doctor, it doesn't make any difference whether you've got a capacity to pay or you don't have the capacity to pay. The issue around a co-payment system, if you're earning enough money where you can actually contribute more to the system, you'll be asked for a co-payment system. It doesn't limit the access to the service. Only if you've got private healthcare cover, which people do in Australia, then you can get into the private healthcare system, which quite often gives you quicker access to specialists, particularly. But it doesn't deny those in the lower socio-economic backgrounds to be able to access their healthcare quicker than what you can here in Canada.
Still, the challenges in our health system are limited to wait times, right? And we can discuss a copay, sure, but in my opinion, we have enough money in the system to do it well, but we aren't. So what are some other challenges that we face?
Our system isn't managed. The problem we have is we have a lot of really excellent care providers, medical doctors, hospitals, allied providers, specialists. They don't always talk to one another because they're very busy, and we have a disrupted system. What we need is what other industries have, and that's project management, process management, logistics management, where we understand that the process should be all about the patient traveling through a system, which, by the way, also includes allied providers who aren't covered by a provincial plan, or maybe social service providers, maybe family counselors, all of whom need to be somehow connected through a system. That's why we believe at CARP Health 360 that there should be a way to take that patient by the hand and take them through the system and then allow the providers to do what they're really good, provide health care.
All right. When we come back, I sit down with Ontario's Health Minister, Christine Elliott, to discuss Ontario's plans to overhaul its health system. That's next.
We want to bring healthcare, first of all, into the 21st century with our digital First for Health strategy. We want to make it easier for people to connect with care, to connect with their healthcare providers.
Welcome back. Last February, Ontario's Minister of Health, Christine Elliott, introduced a plan to overhaul its health system. Some have called it the biggest change since Medicare was created half a century ago. As this transformation is underway, we sat down with the minister to see how it's going. Take a look. Minister, thank you for taking the time.
Pleasure.
I'd like to start with your reaction to the Auditor General's report, which found, among other things, that every year 70,000 patients in hospitals are injured while receiving care. It also found that many hospitals don't comply with the required safety practice standards. And we also learned that many nurses that are fired for incompetence go on to be rehired at other hospitals. So my question is this a policy issue or is this a management issue?
Well, first of all, I respect the Auditor General's work. We have had the opportunity to discuss the provisions. I think it's really important for people to know that our hospitals are safe, that people do not need to worry when they go into hospitals for care. Can we get better? Absolutely. I know there are some issues with respect to some of the practices in hospitals. We're working with the Ontario Hospital Association to improve that. With respect to the issue of nursing and some other healthcare staff, we want to make sure that we can work with the College of Nurses to make sure that we have some provisions to make sure that people who have performance issues, that's flagged.
We also learned that long-term care homes are not meeting quality dietary standards, including one incident of a home that served liquid eggs that were 3 months expired. So my question is, was anyone fired for this? Was there any sanctions put against that home?
Well, I can tell you that that is not adequate, that our seniors deserve much better than that. They deserve to be safe and comfortable and to be eating food that is of the highest quality. So that is something that is going to be followed by the Ministry of Long-Term Care. I work very closely with the minister there, and I know she's very concerned about that issue and is working with all long-term care homes on that.
Good. And the reason I ask is because there's a perception among our members that there are no consequences for failure when these things happen. So I think they really need the reassurance that the government is going to act on this.
We definitely are going to act. It's totally unacceptable that these issues happened with the expired eggs, but there are several other instances that the Auditor General commented on. It's important that we know about that, and we will be taking action.
You ran last year in the provincial election on a platform to end hallway medicine.
Yes.
Are you still confident that under your watch you'll be able to see the end of that?
Yes. Yes, absolutely. It's not a simple issue, as you probably know. It's a lot. It has to do with the number of people who are in hospitals because they're deemed to be alternate level of care. Many of them are frail elderly seniors who are waiting for placement in long-term care homes. We know that there is really a lack of long-term care homes across the province. So again, it's an issue where I'm working with the Minister of Long-Term Care to develop those spaces in order for people to be able to move out of hospital. People don't want to be in hospital longer than they need to. We also need to make sure that we are dealing with the issues of mental health and addiction, that there are many people that cycle in and out of hospital emergency departments when they're in a crisis because there's nowhere else for them to go. So we're building up community mental health and addiction supports. We're also working on chronic disease management. Again, a lot of people, particularly seniors with chronic medical conditions, end up back in emergency departments. We want to make sure that people can stay well and healthy in their own homes.
Now, you also announced a major overhaul to the healthcare system, the biggest, many are saying, in 50 years since the introduction of Medicare. So let's talk about what some of that entails.
Yes, we've just announced the first 24 local Ontario health teams in the province. They were selected from 150 applicants that we heard from that wanted to create local teams, and these 24 are now going to be able to plan and implement healthcare within their particular geographic areas. So we're really putting the ability to plan at the local level. This is a big change from the way it's been planned before, where it's really been the Ministry of Health that has had the relationships with hospitals, with long-term care, with home care, but they haven't been able to collaborate and communicate. We're changing that now so that they can fill in the gaps that they know already exist to make sure that people get fully integrated, fully connected care.
Now there's a real, as you'll know, a real divide in terms of healthcare delivery between urban and rural Ontarians. How will these Ontario health teams address that discrepancy in health delivery?
Well, because they're going to be based on a local geographic area. So the healthcare needs of people in Toronto, downtown, will be very different from the healthcare needs in rural Ottawa area, for example. But it's going to be up to the local teams that are based on certain geographic areas to be able to plan and deliver care for their populations. They know best what the issues are, and we think it's important that if they're delivering the services, they should be able to plan for them as well.
And my last question is this. Every leader that has come before you has pledged to fix this healthcare system one way or another. Why should Ontarians have confidence in your plan? Why will your plan be different, and how will you guarantee that you execute on it?
Because we are changing the way that service is being delivered. We are looking at everything in our healthcare system right now in terms of delivery, but in terms of the issues that are outstanding. We want to bring healthcare, first of all, into the 21st century with our digital First for Health strategy. We want to make it easier for people to connect with care, to connect with their healthcare providers that will be able to have discussions with each other, with the patient's consent, of course, to make sure that they can connect care for that person and make sure that the best possible health outcomes are attained for that person. So it's not one thing we're doing. It's easy to explain why we're doing it, but I can tell you that there are many, many moving parts in this, and we are all committed to making sure that we do this properly for all Ontarians.
Fantastic. All right, Minister, thank you for your time.
My pleasure. Thank you.
All right, when we come back, the panel will weigh in on that discussion. Don't go away.
One thing the minister said, which kind of disturbed me, is that that individual who has breast cancer, perhaps in Ottawa, in Northern Ontario, in Toronto, their needs are the same.
Welcome back. Before the break, Minister Elliott spoke about Ontario's overhaul to its healthcare system and stated with confidence that this transformation would resolve hallway medicine. Dr. Gandhi, what do you make of the PC government's proposal to reduce silos, streamline the system through this Ontario health team model?
I think there's a lot to like in this model. We've been working very closely with the government and providing advice on this model. And if you look at similar models across the world, because this type of concept is used in many European countries, it's used in the United States in something called accountable care organizations, and I believe it's also used in Australia. And the successful versions of this model that they're proposing all have three elements in common. The first element is they need strong physician leadership. The second element is that it needs to be based in primary care. And the third element that's necessary is a strong healthcare IT system to allow the transmission of data, to allow patients to access their records, and to allow the patient care, to allow these models to provide patient care that is centered around the patient. So if the government continues to focus on those three items, I believe that in the long term, there will be successes.
One of the most controversial aspects of this also is that hospitals are at the helm, that it isn't based in primary care. I see you nodding there. So, you know, and so how do we make sure that the focus isn't in the hospital, that some of those smaller voices get a say in this new health system?
Well, hopefully the budgets that hospitals currently earn to a certain degree need to be transferred. If the amount of money in the system is not going to change, and it probably doesn't need to be, then what needs to happen is there needs to be a transference of budgets down to primary care, home care, advocacy, management. Will that happen? I don't know. I mean, that's a real challenge. But I can tell you, in well-run systems, universal systems in other parts of the world, hospitals have actually reduced the numbers of beds, taken the budget, moved it to primary care providers, and moved it to advocacy so that the patient journey can be better managed, because by and large, hospital visits can be prevented. Emergency visits can be prevented if there's a proper system in place to hold the hands of the patients running through the system. One thing the minister said, which kind of disturbed me, is that that individual who has breast cancer, perhaps in Ottawa, in Northern Ontario, in Toronto, their needs are the same. They need all the healthcare services, social services, support services that are required. So one of the things the OHTs are going to have to contend with is how do we move between OHTs? Because the fact is, a person in your riding who has cancer is going to end up coming to another location where there's a specialty hospital which has a totally different system in place, perhaps in Toronto, perhaps in Sudbury, who knows. The point is, how are we going to get who is going to advocate for that patient?
My concern is that every province and territory wants to go and do something better or newer than the other province. And are we just moving the chess pieces around the same chessboard rather than actually making the chessboard better or bigger or creating a new game? So are we creating a new game? I'm not sure that we are.
What would that new game be? A national healthcare system?
I'm for...
By national, I mean governed.
Okay, so all right, I'll talk in the Australian context. I lived in Western Australia, but I worked most of my time in Canberra. But the states or the provinces delivered the primary health care and the health care at the hospitals, but the federal government actually administered a national system. So the provinces were given transfer payments to manage their healthcare systems, which equalled around 60% of their budgets. So the federal government had much more control over creating and making sure that there was a national standards and national access. So it didn't matter where you lived, you could access primary health care, hospitals, same costs, same services.
It makes a lot of sense, but the problem is it's not Australia, it's Canada, and
No.
we have our provinces and territories, and we have to work within the system that we have. So I agree that ideally we would have one system, one unified national health record for everyone, a unified national vaccination registry, a national pharmacare. This makes sense. This is what would create the efficiency that we so lack. But instead, we are siloed to some degree. It's not, I don't think this is going to change. We have our provincial and territorial plans, and that's not up for debate. So given
but
the...
I mean,
It is.
it wasn't always like this. I mean, when Tommy Douglas created Medicare, Medicare was a system that was available to all Canadians. Care was going to be based on needs, not on ability to pay. Your visit to the hospital, your visit to the physicians were all going to be covered. And we had that for a very long time.
But the power was given to the provinces.
But the federal government maintained power over all of the province and the territories because they paid.
The transfer payments.
Through the transfer payment. Now the transfer payments for health have gone to such a minute amount of the overall amount that province and territories spend on their healthcare system that they say to the feds, if you want us to listen to you, you're going to have to pay up.
The one thing that none of these geniuses have figured out is what's the map look like? I'd be happy to have phoned in the old days 3 years ago a CCAC and got a clear answer of where I could go for what. They didn't have a clue where to send me.
And that's why
They didn't have a clue where to. The
That's right.
CCAC, good luck. If you phoned this CCA and you got a nice person who knew her way around, she'd say, go see this clinic. Go. If you phoned somebody else, they could tell you you didn't fill out Form 3B. Click. So they're working at a high level, which they must, and I agree with the doctor, it's fabulous. But they also need somewhere in the system, maybe an ombudsman, maybe somebody says, I'm the voice of the consumer. How easy are we making it for the patients to navigate this jungle that we have created? And the answer is it's not very easy right now.
All right.
Well, it'd be much nicer if we could actually get people not to have to navigate the system.
Exactly.
Yeah.
So if we actually had more emphasis on health promotion and prevention
Disease
than what we
prevention.
do today, and it's not, our care system is not necessarily based on a medical model, we would be much better off.
But there's always going to be some level of hand-holding
All right,
necessary.
I'll give
to
you
take you through various providers and various opinions.
I'll give you an example.
Final word.
Canada spends roughly around 10.4% of its GDP on healthcare. Of that, 0.06% is spent on preventative healthcare and health promotion. Of that 0.6%, 44% is monitoring current comorbidity conditions. It's not about health promotion, it's about monitoring. So we need much...
That goes back to what Marissa was describing. The system was based originally on a young patient population with acute care needs, not an aging population with chronic, complex needs. And so I generally applaud the movement that's being made towards more digital health. I would just add to that, we need to expand on patient portals of access to their own primary care records. The record belongs to me. I want to see it 24/7 wherever I am in the world. That's number one, and we have to make better use of it as an educational tool for patients.
All right, well, there's more after the break. Stay tuned.
We have this fragmented programs where hospital has their EMR and primary care has their own and public health has their own and the lab has their own. They don't connect.
Welcome back. One of the biggest gaps gaps in Canada's health system is that information doesn't always follow patients when they transit from one part of the system to another. For example, far too often, when patients are discharged from hospital, the family doctor isn't kept in the loop. This makes it difficult to get a complete picture of a patient's health record, which is why CARP introduced CARP Health 360, a personalized online record platform that empowers patients to manage their own health records, particularly in the absence of a single EMR. Now, I think both of those two things can coexist. An electronic database that you yourself are empowered to manage, and then one that our hospitals and our doctors run on. But let's talk about CARP Health 360 for a second, because I love it.
The whole concept around CARP Health 360 was to empower people to take more responsibility, to understand where they are in their healthcare journey, what medications, what conditions, what allergies. It helps them understand a little bit better about what's up with their healthcare situation. It also allows them to have a documentation record that they can take to a provider and say, here's who I am, here are my issues, here's what I want to talk about. Because the fact is, digital health is very important, EMRs, very important, but the fact is, just because information gets to a doctor doesn't mean that doctor actually looked at it before you walk in the door. And the issue that we're trying to really stress in CARP Health 360 is the management. What's next? Like, what is the next series of tasks that need to happen with my journey to ensure that all of the touch points are met and followed through?
But when we talk about an EMR, a real EMR that is used by doctors and hospitals and labs, you know, I think Ontarians hear that and they recoil, because they remember the days of e-health and the waste and billions of dollars that was spent on it. The infrastructure is there, the technology is there. I don't understand why it failed and why we haven't caught up with the rest of the world on this. Iris.
E-health has not failed. I mean, I understand. There was $1 billion that got lost, but let's not translate that into some kind of catastrophic forever failure. That's not what's happening. What's happening is that we have disparate EMRs that don't communicate with one another. A basic problem that should have been addressed right from the get-go. But that's what we have. So my contention is that by allowing patients portals of access to all of their records, that problem is helped. It's not completely solved, but it's certainly helped. And moreover, that system could prompt that patient. Your mammogram is due, your colonoscopy is due. It's time to get your blood tests rechecked. You know, it can prompt your doctor, and it can serve that function. All the technology is there. The question is, we're not taking advantage of the technology to the degree that we should be.
It's a no-brainer. Dr. Gandhi?
It's very unfortunate that CARP had to develop this, actually. I mean, I understand the reasons why, but they've developed this because successive governments have failed to deliver an appropriate solution for the patients of Ontario. And I think that's very, very unfortunate. What we really need is we need to have some form of integration. Because right now, at last count, there were something like 90 different patient portals that are available in the province right now. And that's a bit ridiculous, right? You want to have just one portal for the patients of Ontario that allows them access to their health care records, that integrates with the EMRs and with the healthcare information systems in hospitals. To have 90 is just plain silly.
I would say there is such a pent-up demand out there for people who want to have access to their electronic health record. The people want this, but at the same time, there are like privacy issues that needs to be looked at. Do we really want Googles to know exactly when you had your last mammogram and pap test or anything else going on? So all of this is not as clear-cut as can be. I mean, I was there. I'm the one who called for David Kaplan to lose his job as a Minister of Health because the Liberals spent $1 billion paying their Liberals insider rather than building a health record. Now we are years later. We have this fragmented programs where hospital has their EMR and primary care has their own and public health has their own and the lab has their own. They don't connect. And sometimes when they connect, they have those little portals where other people who should not have access to your personal health record suddenly gain access.
What we're looking at here is always balancing out costs. It's not the cost of security versus zero. It's the cost of security versus the cost of what we're currently doing. So the vast majority of Canadians even though there are 90 potential patient portals, do not have such access. What my contention is, the cost of what we're currently doing far exceeds the potential cost of security. I figure that if somebody can manage their banking information, they can manage their health information. We're not giving them the information they need.
But that
we're not providing them with information and prompts at the time that they're needed.
On that note, when we come back, we'll take questions from the audience. That's next.
My neighbor has basically run through her savings, and she's going to have to look at selling her home in order to maintain her husband in the long-term care facility.
Welcome back. We'll take questions from our audience now, starting with yourself. What's your name? Welcome to the roundtable.
My name is Susan Gaselewski. My question concerns long care facilities. I know that there's a shortage. I have a personal interest because of my neighbor. Her husband, he was in the hospital for well over a year before he was able to be transferred to a long-term care facility. And now, of course, the costs keep going higher and higher and higher. It's gone to a point where my neighbor has basically run through her savings, and she's going to have to look at selling her home in order to maintain her husband in the long-term care facility. So is the government looking at anything to provide any type of assistance, to put a cap on the costs from continually rising and rising?
My question would be, is it a care facility which is subsidised by government, or is it a private for-profit care facility which doesn't get subsidies from government? So it's a full out-of-pocket expense in that case. But if you look at Ontario, generally the subsidies that the Ontario government provide to long-term care is around $150 per day per patient, per resident in the home. And the individual should not necessarily be out of pocket to a large extent that you're talking about. I know some people in this audience will probably know people that are in retirement villages or retirement homes, and it's costing $5,000 or $6,000 per month.
No, but Greg, even there are 78,000 long-term care beds in Ontario. Your friend's husband is part of the 34,000 people waiting for a long-term care bed in Ontario. And although long-term care are financed by the provincial government for the care, they are dominated by the for-profit. They are allowed to charge, and they will charge the minimum amount that you will pay to go into a long-term care home is over $1,800. You want semi-private, it will be over $2,000, and you want private, it will be more than this. Unfortunately for couples, and this breaks my heart every day, they don't only look at, they look at the couple's how much money they're taking in before the government stepped in to help. They don't take into account that the spouse that's left behind in the house still has the exact same expenses. The cost of electricity and the phone and the taxes are exactly the same. The government doesn't look at this. It looks at how much money you bring in. If you have old age, if you have CPP, you will be paying the full amount to live into a long-term care home. If you go into a retirement home, the homes you're talking about, then the government doesn't pay anything for this, and you're on the hook for $5,000 a year. Not $5,000 a month to in a retirement home.
But you also have to think about the impact it's having on the spouse that's at home, because she's absolutely devastated. She really is. I mean, it's really weighing her down. She's not the person she was 3 years ago.
The devastation is horrible that she's suffering. But I want you to pull yourself away from the devastation of the individual and consider for a moment the devastation to a system that is paying every day for an acute care bed when it could be paying for a chronic care bed that is a fraction of the cost. That there's other costs to that acute care bed. What if my father is the one waiting for that acute care bed that her husband sits in for a year? That's what's happening in our intensive care units. That's what's happening in the hallways of emergency care. That's what's happening in the wards. And that's the bigger problem. So with due respect to your friend, and my heart goes out to her, there's a lot more implications to that. While he sits, other people wait, And the system is suffering in terms of sustainability.
And what do you
because that
think,
acute care bed is way more expensive than the chronic care bed would have been.
Earlier in the discussion, Dr. Gandhi said something about IT. They should have thought of this 15 years ago on that topic. I'm not talking about IT, but same thing with long-term care. Because if you think you have a problem today, what do you think's coming?
Okay, here's what I think. My panel should be on an advisory committee for the government. When we come back, final thoughts from our panelists. That's next.
In another episode of The Zoomer, we discussed caregivers. Oscar writes on Twitter saying, "At what point do Canadians realize the current healthcare system is inflicting incredible harm on people who need long-term care? The system must be dismantled and recreated. It needs to focus its efforts on health rather than profit." #caregivers. In a previous episode of The Zoomer, we discussed divorce. On Twitter, Lauren writes, "I hate to see an ugly divorce or child custody battle. When the love turns into hate and anger, the level of spite, greed, selfishness, and insensitivity that comes out is utterly gut-wrenching. #divorce is hard." Keep the comments coming in. And connect with us on Facebook, Twitter, and via email at rsvp@zoomermedia.ca. Don't forget, for free tickets to the show, go to www.universe.com and search Zoomer Media, and log on to www.thezoomertv.com for full episodes and more.
Welcome back to the Zoomer. It's time for final thoughts now from my panelists, and we'll start to my left, MPP Jelena.
Well, I think I've made it clear that elderly people, the boomers, are not going to agree to move into a warehouse of a long-term care home. They are going to force the government to put new models forward. Those new models can only be successful if we have a strong and robust home care system. So how do you build a strong and robust home care system? You make PSW's job good job. Make our home care system robust, meeting the needs of the people who wants to stay home. And a lot of people don't get in trouble, don't end up in ER, don't end up in the hospital, don't end up on the 34,000 wait list to go into a long-term care home. They stay home with their loved ones where they want to be without burning out their caregivers.
All right, David.
What I'm really saying is that there should be some function within all this that says, number one, we are underperforming relative to other single-payer countries. Let's stop blaming everything on an imaginary enemy at the United States, because what about Australia? Why can't the people in this side, why can't we have what Denmark has and what Australia has, number one? Number two, somewhere in the ministry, someone should be looking at the Zoomer generation, let's say 45 plus, 50 plus, and saying, who are the people for whom we are building all of this? What makes them tick? How do they behave? How do they approach their own health care? And there's no evidence that I can see that this topic even exists. And I volunteer CARP to go and consult with any of them. We'll tell them, you know, how our gang behaves and what we're looking for, because I don't see any sign that they really realize it.
Challenge accepted.
Adopt a really rigorous planning model for long-term care, which includes the provision of long-term care beds in terms of the built environment, but more emphasis around community care services, and not post-acute. I'm talking about the social determinants of ageing, supporting people to remain at home or at the place where they choose to live. And it could be in a retirement village where they were paying $5,000 a month. But the emphasis has got to be on supporting people at home through community care packages. And Canada is one of the only countries that I know where the general perception is that people are going to end up in long-term care. Remember that only 7% of the ageing population over the age of 70 will ever end up in long-term care, in a nursing home. So how do we support the other 25% which need community care services?
I'm going to end on a bit of an optimistic note, though. I actually do believe that we are on the verge of some significant healthcare transformation that will be better in the long run. The transformation will not be easy. It will have a fair number of teething pains as we go along. But I do believe that the advent of the Zoomer generation that's demanding better services because they pay taxes all their life, I do believe that there's a recognition that things need to improve in this country. And I do believe that we're finally going to be harnessing digital health to provide patients with the tools they need to help advocate for themselves. I do believe that's coming actually in a shorter term than most people think. And I think those things will, in the long term, do our country a fair bit of good.
I agree with Dr. Gandhi that many digital health advantages will assert themselves. But I also think that the concept of bringing care to the patient is a critical one. And the best way to do that is empower them with the information that when they need it and educate them with the tools that they need to have so that they have automatic reminders of problems or automatic reminders of vaccinations. And finally, I fear digital health. I know there's two sides to this. Digital health is going in a direction in which the physical examination is being lost. The personal interaction between doctor and patient is being lost. Doctors are now spending over 50% looking at a screen, and that adds to physician burnout as well. We need to bring back the human aspect. And the way to do that is to empower nurses, physicians' assistants, and nurse practitioners to come to people. It's not just a question of doctor does everything.
We need to bring compassion back into this system. We have great doctors, we have great providers, the best in the world. The problem is they live in bubbles. And to expect an individual working through the system who might be cognitively impaired, who might have many, many chronic conditions, who might have difficult family positions or difficult financial situations, to advocate for themselves, even with all the great digital tools that might become available, is not fair. The fact is, ultimately, there needs to be compassion and understanding that when you're really ill, you can't do it all by yourself, and you can't expect your daughter or your son to do it.
Mm-hmm. All right. Thank you to my panel for being with me today for this incredibly important conversation. To the audience and to those watching at home, we'll see you next time. For now, it's time to zoom out.